Look at this MRI image, we see these bony contusion that is related to some mechanism, and that tells us that 80% of them have some sort of cartilage contusion also, and some degree of cartilage lesion as well. And these different X-ray tells you about some sort of degenerative pathology in the joint, and alignment X-rays, this will tell you something bad with the alignment that leads to the cartilage lesion. You need to get an MRI done to check for an associated pathology, and also to identify the cartilage lesion, to characterize it, size it, so that you can decide the treatment. But often MRI underestimate the cartilage lesion in terms of degree, or also sometimes it misses entirely. So the arthroscopy to diagnose a cartilage lesion remains the gold standard, and you need to follow the mapping. You need to search each and every corner in the knee joint to look for a cartilage lesion. And if you see a patient of a cartilage lesion, the decision making is not linear. Why? Because you cannot relate the clinical findings, also the cartilage status. So the symptoms might be due to a meniscus tear, or a subchondral bone pathology, an alignment issue, or a ligamentous instability. So symptoms might be due to something else. You need to also think that the treatment of a focal condyle lesion and a degenerative cartilage lesion is different. For a focal condyle lesion, we are aiming towards the healing of that cartilage lesion, and in a degenerative cartilage lesion, like we are discussing the PRP and the other things, here we are focusing more on symptomatic relief to that patient. So we need to have a multimodal approach. We need to look for the patient symptom. We need to consider other pathologies, correlate with imaging findings,